So good morning, good afternoon, and evening, everyone. A very warm welcome to our Dornier webinar series, COVID-19 Spotlight on Urology USA. We are delighted to have with us today an excellent panel of renowned urologists with representation from New York in the East, San Francisco in the West, and Central Indiana. So I'm Wee Siu from Dornier MedTech, and together with Bob Evanson, we will be your Dornier hosts today. Before we start, I'm just going to cover a couple of quick points. Firstly, whenever we have a slide showing in the background, basically you'll see the speaker in these boxes. That panel you can easily move around just by clicking the top bar and dragging it. You can also resize the window or choose to show one speaker or many speakers. Okay. The most important part, of course, is asking questions. We welcome your questions and hope that you ask them. You can do this throughout the session by clicking on the Q&A button in the bottom panel. And you just type in your question and hit submit. I'll be collating all your questions throughout the session, and we will have them fielded to the panelists and try to answer as many as possible at the end of the session. Okay. The chat function is disabled, so please use the Q&A channel to reach us. Okay, so without further ado, I'm going to hand the time over to Bob, who's going to introduce our panel. And over to you, Bob.
Great. Good morning. Just a quick nod if you can hear me.
Yes.
Great. Thank you. Good morning. On behalf of Dornier and our distinguished panelists, we welcome everyone to the Dornier webinar series. We're honored to have you join us from over 32 different countries this morning, this evening, and this afternoon. Please allow me a moment to introduce today's topic of discussion, introduce our distinguished panelist and moderator. As the United States battles the COVID-19 pandemic, healthcare professionals have been forced to respond in ways never before imagined. And under these unprecedented circumstances, many states are looking to reopen and resume elective surgeries. We're here to discuss how to turn the lights back on. Today's distinguished panelists are joining us from various locations across the United States, as Wee Siu said, and are providing a coast-to-coast representation. I'm pleased to introduce our first panelist, Dr. Amy Krambeck. Dr. Krambeck completed her medical school training at the University of Missouri-Columbia School of Medicine. She went on to complete her urology residency at Mayo Clinic and completed an endourology fellowship at the Methodist Institute for Kidney Stone Research. Dr. Krambeck is a current professor of urology at Indiana University. Welcome, Dr. Krambeck.
Thank you.
Our next panelist joins us this morning from the East Coast, Dr. Ojas Shah. Dr. Shah serves as the director of the Division of Endourology and Stone Disease at Columbia University Medical Center and is a member of the American Urological Association's Surgical Management of Stone Guidelines Committee. Dr. Shah was recently appointed to the American Board of Urology Examination Committee, and Dr. Shah serves as the principal investigator in many clinical research trials regarding the surgical and medical management of stone disease. Welcome, Dr. Shah.
Thank you.
Our third distinguished panelist comes to us this morning representing the West Coast, Dr. Thomas Chi. Dr. Chi is an associate professor and associate chair for clinical affairs at the University of California, San Francisco of Urology. Dr. Chi has been awarded grant funding from the National Institute of Health, the American Urological Association Urology Care Foundation to research the fundamental mechanisms underlying the formation of kidney stones. Dr. Chi is also the 2020 recipient of the AUA Gold Cystoscope Award. We welcome Dr. Chi.
Thank you very much.
Our final panelist and today's discussion moderator also joins from California. We're pleased to welcome Dr. Marshall Stoller. Dr. Stoller heads the University of California, San Francisco's Urinary Stone Division, which includes endourology and laparoscopy. Dr. Stoller graduated from the University of California, Berkeley, and attended medical school at the Baylor College of Medicine in Houston, Texas. He was a general surgical intern, chief resident at the Department of Urology at UCSF. And Dr. Stoller is a current professor of urology at the University of California, San Francisco, and his practice emphasizes the surgical management of urinary stone disease and minimally invasive endourology. We welcome Dr. Stoller, and with that, I will turn the balance of our discussion to Dr. Stoller and thank him for being today's discussion moderator. Dr. Stoller.
Bob, thank you very much for those nice introductions. We do live in some very interesting times with this COVID-19 and how it has disrupted our both personal and professional lives. through the fact that we have a geographic disparate group on the committee, I'm going to first start with Dr. Shah on the East Coast, and maybe you could give us the nitty-gritty of how you have postponed cases, and the ones that you have postponed, how do you keep them updated in terms of potentially filling them back in when your ORs start coming back online?
Okay. Obviously, we were probably one of the hardest hit in the U.S. in New York. So immediately when we were hit with the COVID-19 pandemic, we actually canceled all cases of all sorts in the entire medical center and went down to 0 cases except for emergencies. And even emergencies in the beginning were postponed unless they were life-threatening. So we blocked all of our cases off. We actually compiled a list of them, and we use an electronic medical record system, Epic, which actually stores all of the previously booked cases on a log, basically. So everything was canceled, and everything basically was canceled for about 8 weeks, except for very emergent cases, and then some cancer cases started to reappear. The one interesting thing is endourology has a lot of emergencies out of anything else in the practice. So kidney stones that were obstructing, that were causing fevers, were one of the few cases that would run during this time of the pandemic here in New York. And now that we're about 8 weeks out from our initial closures, we started to put on kidney stone cases that are more urgent, as well as cancer cases, and almost everything else has been postponed. And that's what we sort of separated between elective versus non-elective urology. Anything that was more urgent we would be doing, and all the other subspecialties, infertility, erectile dysfunction, incontinence, voiding dysfunction, have all been slated to later dates. Nothing's urgent on those sides.
Thank you, Dr. Shah. Dr. Chi, are things a little different on the San Francisco or West Coast compared to New York in terms of managing your acute colic patients and this concept of elective surgical cases?
No, I think everybody's had a similar experience in that, patients are, we've been triaging in terms of urgency for priority for cases. I think what's challenging for us right now is that, we sometimes joke that the renal colic just disappeared off the face of the earth. The number of patients who were coming in before with renal colic and needed some kind of emergency or urgent thing done has gone down quite a bit. And so, part of what we're worried about is that, as people have seen in other things like heart disease, neurologic disease, folks may be avoiding the hospital. And so how do we actually get those renal colic patients to come back for safe management so they don't come back later with a larger obstructing febrile stone as opposed to a smaller, easily manageable stone now? So those are the things we're thinking about.
Dr. Krambeck, in the Midwest, in Indianapolis, what's happened with your acute renal colic patients? Are they still there, or have they disappeared like Dr. Chi is sort of suggesting on the West Coast?
Yeah, I would agree with Dr. Chi that COVID-19 has cured renal colic. So we do not see the standard flank pain patients. They're really gutting it out at home. What we are seeing is more advanced disease when they do come in. So high fever, septic, found down at home, and then it's a true emergency. Last week was our first week of opening back up. We shut down exactly like Dr. Shah's practice did, and only performed emergencies. And last week was the first week we opened up, and the cases were far more difficult than what they would have been had we treated them initially. Encrusted stents, infected prostates, infected stones.
Well, I've got you on the line. Who has been in charge, Dr. Krambeck, in Indianapolis? I mean, has it been active surgeons like yourself? Has it been administrators? Has it been chairs? What is the hierarchy of who is in charge in making the decisions? How many ORs are available? How many anesthesiologists are available? And how long the ORs can actually function on a typical day?
So we have a command center, which is basically staffed by the CMOs of the various different hospitals and then administrators. And so they're the ones making the decisions on how many ORs we open. And most of our restrictions have been because of limited PPE. Not necessarily that we can't handle the volume, but we don't have the appropriate masks and gowns to be able to handle a huge influx of patients. So that's why we initially shut down. And now that we have more PPE available, we're opening back up, and we're seeing our COVID numbers rise as we do that.
Dr. Shah, in New York, what has been with the huge surge in New York that you had? What were the limitations with your PPE, or were there any limitations when you came to the hospital?
We were overrun, so our PPEs got very dire straits. We were probably down to within 24 hours of being out of PPE for such a major caseload, because we had probably close to 500 patients at a time in the hospital with COVID, with a high volume of PPE requirements. So we were in those where we were using the PPE for 24 hours, and then actually the hospital I work for was able to gather a whole bunch of PPE at the last second through using major resources and exhaustive resources to try and find PPE. And now we're at a surplus, but we're still limited with our resources. You're not allowed, the government and the governor has mandated no more than urgent cases are allowed to be done at this point in time, urgent including cancer, and then urgent surgeries like kidney stones and other types of things for other specialties. But it's mandated from the governor. Then we have an ethics committee in the hospital that decides whether a case can actually go on or not. So we apply for every case after it's internally vetted by, I'm on the committee in our department that internally vets the case. And then we put it out to the hospital to see if they'll approve it or not. And we have about an 80% acceptance rate for what we're trying to put on.
How are you, do I still have you on the line there? How have you been dealing with testing today versus what it was like 6 weeks ago in New York?
Testing as far as for COVID?
For COVID, both for your patients and for your staff.
So we're in an interesting dynamic. So let's talk about patients first. Within 24 hours, they have to have a negative COVID test prior to surgery. If they have a positive test, then the discussion of urgency of the surgery is discussed by anesthesia, the surgeon, and the patient to decide whether they want to proceed with the surgery while they have a COVID, when they're positive for COVID, because the risks of anesthesia are thought to be a little bit higher with COVID positive, even if they have no symptoms. Now it's been extended to within 48 hours of surgery. And the testing is usually done for most patients on the day of surgery, right before, with a rapid test, which has about an 85 to 90% sensitivity. So there's still about a 10 to 15% false negative rate. For staff, as of this week, everyone can get, anyone that's been a frontline worker or a healthcare worker can have an antibody test done by the hospital. As of last week, it was everyone could have a COVID swab done, but they just opened up antibody testing for everyone in the hospital as of this week.
When you say everyone, what do you mean?
Everyone, anyone that works in the hospital, any healthcare worker, nurse, anybody that's on staff, any physician, anyone that's been exposed, but not even been exposed, has been working during this time period, can be tested for an antibody.
Thank you. While we have this, I'd like to just open up a quick poll for everybody who is participating in the webinar. And the question is, who are the decision makers in ramping down or ramping up in your hospital? Are they mainly the administrators? Are they mainly the department chairs? Or are they active clinicians? And if you can mark that down, we will continue our dialogue here with Dr. Chi. Are the healthcare workers and the nurses in the OR being tested in a similar fashion to your patients? And do you need to have a test within 24 hours, or are you a week, or what is your time frame on the West Coast, Dr. Chi?
On the West Coast, at least in the San Francisco Bay Area, we've been fortunate in that, we never really hit a surge number, which has been good. And our curve is already flattening and case numbers are decreasing. Despite that, I think that we're all facing the similar types of issues as we kind of move forward for how to give safe patient treatment. I'd echo what Ojas was saying in that, the dangers to patients I think are what comes first. There's a couple of small papers that say that even if you're asymptomatic and you're carrier, if you develop symptoms afterward, after surgery, your mortality can be quite significant. And so, we worry that whether patients are symptomatic or asymptomatic carriers, that testing is going to be really important. And we don't know when that's going to end, so it was obviously really important when case numbers were going up, and you didn't want to overwhelm a system and get people really sick. But how long that's going to be relevant and important is hard to say. So we've continued doing asymptomatic testing for all patients. For us, our time limit is 4 days ahead of time, but there's no data really that run these types of decisions. So just down the street at one of our sister hospitals, as part of our affiliates, the timing is 7 days. And so for patient testing, it's really hard to say, because the challenge is that if you test a patient, then could they get exposed between the time you got tested and the time that you actually did surgery on? So how useful is your testing? So those are the kind of decisions I think people need to make based on their local infection rates, and work with kind of Department of Public Health to understand that. And for staff, similarly, the antibody testing coming on the market, I think, is a good thing. Hopefully, it's going to give us some level of clarity. But right now, that 85% sensitivity, I think, is what troubles us, is that we don't really know if that's good enough, and so we've not been testing providers or staff. But hopefully, as testing becomes readily available and more accurate, that might change over time.
So here you can see the results of our poll, that it looks as though the administrators were 2/3 of the time the main decision makers at hospitals around the world. The department chairs about 20%, and the active clinicians were involved only about 12% as being the major decision makers. That poll's been very helpful. Let me just go back to you, Dr. Chi, while you're still on. Could you just emphasize, what about the people in the actual operating room? The x-ray techs, the anesthesiologists, the anesthesiology techs, the surgeons, the assistants, are they being tested? And if so, how often are they being tested?
So right now for us, we're not testing anybody as asymptomatic providers or staff. And so, others around us have initiated that. And so, you've heard various strategies from, we're just going to test everybody every 2 weeks to, well, we'll just test you once. And then as long as you're negative, we'll just keep going, stay out of trouble. And I think that those decisions are really challenging. I think they're limited by the amount and capacity of testing that people have locally, as well as kind of local disease patterns. And so, I think that any clinician really needs to work within their system to, one, stay updated, because these things change day by day and week by week, obviously, as supplies change and infection patterns change. And also kind of work in the team, because the problem is, if there's one exposure in a team, it can knock out an entire group of 10, 14, larger than 14 people for a long period of time. So being careful about exposures are a really important thing, first of all.
Thank you, Dr. Shah. I'm going to Dr. Kram. Dr. Shah, you had something to say?
Yeah, one quick thing is that in the operating room, because of the false negative rate and because we don't know what the exposure is to the people in the hospital and the employees, we basically go into full PPE when we operate. So you're wearing full gear, get goggles or face shields. You have a N95 with a surgical mask over it. So you're operating through full gear when you operate, just to prevent exposure that you would not know, occult exposure.
Is that difficult during like a percutaneous case with lead on, or during a laparoscopic case for you?
Everything. We are not going to be doing PCNL anytime soon unless it was urgent. It's basically left with stenting, ureteroscopy, and nephrostomy tubes for now, just because of resource utilization. We hopefully will be able to do them within the next few weeks. But it's for any case. Everyone, I think, is fully geared up for any case that they go into. Right now.
Dr. Krambeck, in the Midwest, well, what's the status in terms of testing for both the patients, for the staff in the OR, and are you operating with full PPE on all cases?
Yes, so very good question. So the patients have to have a negative test within 72 hours of the procedure. We are doing PCNLs and HOLEPs and ureteroscopies, so anything that we would consider urgent or time sensitive. Most of the PCNLs have indwelling stents or nephrostomy tubes or infection, which is why we're doing them now. If the patient tests negative, then we do not do the full PPE. We do not wear an N95. We wear eye shield, mask, but not the N95 and the rest of the gear. So if the patient is unable to complete their testing, but we feel that we need to go forward, then we would use the full armamentarium with the N95 mask. I think the reason we've not adopted testing for staff, only symptomatic staff can get tested, is that I think it's important to remember that all of these tests were approved very quickly and may not have the sensitivity and specificity that we would want in a standard test. So that's why our hospital has said we're not doing mass screening. We are only testing symptomatic individuals to improve the sensitivity of the test.
Well, it's very interesting seeing all the differences, in New York being 24 hours, in Indianapolis being 72 hours, in San Francisco 4 days. So you do sort of see that there is not a consistent plan completely around the United States. The big issue that a lot of people have been concerned about are what are the financial implications for the institution for the ancillary staff, and for the surgeon. So, Dr. Krambeck, while you're on the line here, what are your thoughts, or what has been the reality? Are they cut physician pay in terms of take-home pay? Are they anticipating cutting pay? Are they having to furlough nurses or staff? What have been the financial implications for you in the Midwest?
So I feel exceptionally fortunate to work at IU. They have not cut physicians' pay. They have not furloughed staff. They have redeployed staff to ensure that everyone continues working, and allowed people to work from home. So there's no anticipation in the near future to cut our salary. I know it's not been that way at all locations, but they plan to pay us what we would normally make as long as they possibly can. And they've done that for every single employee in the hospital.
Well, that's nice to hear. Dr. Chi, what is the status on the West Coast in terms of financial implications for now, and what do you sort of see as the future?
Well, I think that similar to Amy, with the UC systems, they've made that similar decision to not furlough or lay off or reduce pay, at least through June. But I think everybody everywhere is taking a huge financial hit, from large groups, big academic centers, to LUGPAs, to small practices. So I think that as we look forward to kind of how you turn the lights back on, I think that there's going to be a huge emphasis placed on value-based care. It's been something that I think that folks have been interested and driven towards in the last 10 years. Obviously, we haven't reached bundle payments quite yet, I think in endourology, for example, but they're doing it in orthopedics, they're doing some colorectal type bundle cases. But I think that approach to care, how much of the care can you get done in a single episode? Because it's a benefit to patients. I think it's going to be financially more salvageable. And I think that we have to be thoughtful about the financial implications of the decisions that we make, because the reality is that if every institution, if every hospital system actually took such a big bath that they couldn't actually keep the doors open and had to start laying off people and furloughing, I think morbidity is going to be really increased across diseases. So I think all of us as a community, as physicians and providers and surgeons, we're going to really need to be focused in on this value-based care idea. Can you shorten the number of episodes? Can you keep patients in an outpatient setting as much as possible? Can you work with instruments that are less costly, or deliver faster care in the same time frame? I think those are going to be really important principles.
Dr. Shah, I'm going to be back with you in one moment, but we do have another poll that's up to get everybody's perspective from the webinar. And the question is, what is your top concern regarding turning the lights back on or getting back to your, quote, normal practice? Are you concerned about adverse effects such as severe complications as a result of the delayed surgery? Are you concerned about patients being afraid to come into the hospital, or are you afraid of the COVID-19 resurgence? And as you answer those questions, I'm going to go back to Dr. Chi for one moment while he's there. How are your referrals in terms of people coming into a tertiary center? Are your referrals the same? Are they up, they're down? What do you anticipate in the future? And then I'm going to go to Dr. Shah to get his perspective in New York.
Yeah, even though we're in a phase where folks recognize that the number of cases is going down, I think the amount of referrals has gone down quite a bit. And so, folks are probably experiencing this to varying degrees everywhere. And it's hard to know right now whether that's because our referring physicians, whether they're small practices or other types of settings, are themselves not open and therefore not seeing patients to refer them on, or is it that patients are concerned about coming in? There's lots of things that we do right now aligned with the DPH, like a no visitor policy at the hospital, for example.
I'm sorry,
which
Dr.
I think
DPH is Department of Public Health.
of Public Health.
Right.
Department of Public Health. And so, we're not allowed to have visitors with patients in the hospital when they come in for surgery. And so, for a lot of folks, that's a big barrier we found, is that, they themselves don't want to go to the hospital because they're afraid of going alone. And so are these patient-centered issues the reasons why we're not actually having patients being sent over and being referred and seeing new consultations? And so how do we manage that set of expectations for patients, and also keep aligned with government officials and public health rulings around us, so we can deliver care safely? Those are kind of things that are at odds with referrals.
Dr. Shah, what is it like in New York? Are you allowing family members to come to the hospital when you do the surgery or when they're an inpatient? What are your referrals like at the present time, and how are you managing them?
Those are interesting questions. We actually do not allow any family members in the hospital at this point in time. So on the surgeries that we perform, the patients are dropped off and we wheel them out to their family member when the surgery is done and they've recovered. So recovery room time is actually longer than before because they have to be like fully awake and fully out of anesthesia before they can be discharged home. And we are trying to limit all surgeries to outpatient type of surgery, at least in the urology world so far. Until this week, I think we're starting to do some prostates and kidney surgeries that are actually on very high grade types of cancers. Referrals are coming through, but we are doing most of our first initial visits via telehealth, which where you're asking earlier, or you were going to ask us at some point, we were about 5% telehealth before this whole thing started, and we're about 95% telehealth right now. We've done a dramatic change.
Yeah, Dr. Krambeck, what about your perspective? Are the referrals still there? And with your backlog of postponed patients, how are you trying to integrate them with the continued referrals that are coming in? How do you prioritize those?
So I would agree with both Dr. Shah and Dr. Chi that referrals are way down. And even when I do get the referral, it's difficult for the patient to actually show up. So like this morning, I had in-person clinic and my no-show rate is around 60%. Like patients just can't quite get out the door because of fear. We were 0% telehealth or virtual medicine, and now we are 75%. So almost all of our visits are virtual health. Right now, we have 1,600 cases in our department that are on standby, waiting to go, just for the Department of Urology. So right now, they've reopened elective surgeries in Indiana. So we're just trying to get them done as quickly as possible, anticipating another surge, so that we can handle the backlog first before the new cases come forward. But if we have a patient that we see that is new, a new referral that's urgent, then they will postpone a patient who's been waiting who is less urgent. So it's very difficult to determine. And what we've asked all the surgeons to do is to prioritize their patients as should go in the next 2 weeks, needs to go within 6 weeks, needs to go within 3 months, or can be deferred indefinitely, so that we have an idea of who needs to go when, and it's a running tally at all times.
Thank you, Dr. Kutzmann. I'm just, here's the results of the recent log. What is your top concern regarding turning the lights back on or getting your practices back on? The adverse effects, such as severe complications, about a third. Patients being scared to come into the hospital, like Dr. Krambeck just suggested, 33%, and a resurgence. So about a third each. So this is very interesting. That's very similar. While you're still there, Dr. Krambeck, what capacity is your OR? I don't, let's say you have X number of operating rooms. Are you back to 100%, 50%? Are you 4 or 5 days a week? How are you trying to deal with these 1,600 cases that are backlogged?
So we are at 25% of what we were at normal running time. So like at the Methodist Hospital where I am, we have 2 awards dedicated to urology every day right now. Normally it would be 3 to 4. We got a little more than 25% because our backlog was so high for urology. So we actually have block time that we're able to utilize, and we are utilizing every single minute of that block time. They're talking about allowing us to work at night and on weekends, hopefully in the next week or 2, so that we can address this backlog. But currently, we only have 2 rooms every day, 5 days a week. So we have to prioritize which cases go.
Dr. Chi, what about you? How are you dealing with your backlog? Are you working on Saturdays? And if you are they incentivizing you in terms of encouraging you to do that? What kind of incentives are they giving you if they want to try to increase capacity?
Well, I think that Dr. Krambeck's comment about, the surge, and then, a third of the people on the poll being worried about that second resurgence is probably a really important comment, is that, for us, the backlog, the institution kind of pivoted very quickly. So we went from being like, no cases that are not going to kill you within the next day, to suddenly, okay, I think we're in a safe place and let's really turn it up so that we can get as much done now as possible safely, so that, you know, one, we don't run into another surge, and two, we get this backlog done. And, you know, it's been a remarkable thing to watch and also to think about too, because it makes sense in that when you've got testing and capacity and you've got equipment, then I think it really changes the game for people to actually be able to address these things as quickly as possible. Because if you can deliver that care safely, then you can get through that backlog faster and do things like Saturdays and nights. And but I think that you have to be able to recognize that those are, to me, I think those are the important factors. So, you know, knowing what your local test positivity rate is, being able to test and having the right equipment to be able to do your cases. So, you know, here where we are testing asymptomatic patients before surgery, we're only seeing about 0.3% positive. And so we know that the margin of safety is quite high. And so we can run kind of full block times for the cases for the services that have really large backlogs. The incentives on the weekends and kind of around times that are not normal for you, I think that with institutions being hit so heavily, it's going to be hard for them to incentivize you beyond what your normal billing expectations might be to do these extra cases. But, you know, on the flip side, I think that every surgeon's hungry. You know, like no surgeon was ever born to sit around on their hands. I don't think that's just not our nature. And so I think people, you know, recognize that they want to get the care to the patients that they want. And so that, you know, to be honest, that having even be in a conversation on the table. I think people just want to get the patients the care that they need.
Thank you. While you're still on the line, Dr. Shah, what is the trick of dealing with like an 80-year-old or a 70-year-old who's not really that facile at dealing with the internet? How have you been able to transition to telemedicine and to get them onto a type of video encounter?
So, you know, the things, at least in the U.S., that have really changed for us, our ability to develop, to deliver telehealth, has been the loosening of billing guidelines really across the board. So now you can bill for telehealth at the same level that you would for an in-person visit. And then most recently, just I can't remember if it was last week, the week before, they changed telephones as well, so that they're being reimbursed at a much higher rate. And you can go across borders between states, and so interstate licensure has been relaxed as well. And so, you know, we used to think that, oh, you know, it's the octogenarians, it's the 80-year-olds that can't do telehealth. It's a huge barrier. Nobody can do it. And I think it turns out that the technical barriers for people to be able to do telehealth, it kind of extends across age. There's no ageism in the technological barriers. So we have some people who are in their 30s who just can't figure out how to turn the microphone on. And other people who are in their 80s are like, yeah, no problem. I do this with my grandkids all the time. It's very easy for them. But I think that what's kind of helped us as a system is that with the loosening of those reimbursement guidelines now, there's very little disincentive for you to switch right from a video visit to a phone visit now. So, you know, if you're on a telehealth with a person and they just can't figure that phone button out to get the sound working, rather than spend an hour trying to troubleshoot them right there, just call them on the phone. You know, everybody knows how to use a phone, and you can build those with different codes. So you have to be familiar with the codes, but you can build them on time for telephone and just flip the visit right there. So that's been an effective strategy for us.
Dr. Shah, do you believe that telemedicine is the new normal now and in the future?
I hope it is. We've realized that it's actually very, very effective and very useful. It saves us time. It saves patients time. It saves a lot of costs from transporting to the hospital. I think there's going to be definitely a role for live visits, but for a lot of routine follow-up, especially for endourology, I think a lot of it can be done via telemedicine, especially for our patients that come in from 1 to 2 hours away. It's such a time saving. If the government allows us to relax the restrictions like they have right now, to some degree in the future, it'll be fantastic for us. Even for new patient referrals, there's a whole world of like second opinion medicine that's you know, UCSF may have it, Indiana may have it, Columbia University has it, where people would call for second opinions and pay a service for that. Now that may disappear because they can get a second opinion. Hopefully it's not abused to the fact that people will get 17 visits with different people for the same opinion for the stone, because now you can call San Francisco, you can call Indiana and New York to get your opinion. But I think there's definitely a role for it in the future.
Dr. Krambeck, with this change, have you had to implement any emergency credentialing for physicians in your medical center, for instance, if they were retired, or if they were from out of state, or they did not have their normal licensures in Indianapolis or Indiana. Have you had to do any of the emergency credentialing in your area?
We have not. Our governor reinstated all retired licenses, so physicians could come back to practice, as well as allowed APPs to work independently without association with the physician. So that helped with the workforce as well. So with us on virtual medicine and telemedicine, we are not allowed to see new patients outside the state. So they have worked to get us credentials in the surrounding states so that we could handle Kentucky, Illinois, some of the more commonly, states that more commonly refer to us. So we all have gotten credentials in those locations to handle new patients. But beyond that, we're not allowed to see new patients outside the state.
So while you're still on the line there, Dr. Krambeck, I know you've got these cute little kids. When you've had to work from home, how have you negotiated your kids and work, telemedicine, if you're doing it from home? A lot of us are going back and forth from the hospital and at work. How have you negotiated these juggling that you've done in the past, but now all in the same location?
It is unbelievably difficult. I mean, I am very much a boxer. So like if I work at work, I work at work. And then when I'm home, I'm home. And trying to merge those two worlds has been unbelievably difficult. I feel like I work all the time. And then my children frequently walk into visits and webinars, and it's just extremely hard to find that separation. I have the utmost respect for the teachers out there trying to homeschool my children when I'm not a teacher is very difficult. And I'm tired, like I'm ready to come back and work 50-hour days because it's a lot easier than staying at home.
Yeah, I can imagine. Dr. Shah, I know you've got kids at home too, all running around. How have you tried to balance? It's not really work life now; it's all combined together. How have you tried to deal with this new smorgasbord of everything happening at once at the same location?
Well, you know, I think Dr. Krambeck's comment about just feeling like you're working all the time is never been more true. You know, like with telehealth now, we're blurring the lines between what's on hours and off hours. We want to make sure our patients have access to talking to folks. So, you know, they're texting me or calling me, you know, whenever odd hours, because I don't want them to feel like they're unsupported. So, you know, all the lines are blurred now. And I think that it shifts the home life balance, you know, I think regardless of what your dynamic pre-COVID was. And I think that, you know, to be honest, I think people need to kind of lean into that and recognize that it's a stressful time, not just for you, who's the provider for your patients, and, you know, you had your job before, and you had your home life, and now you got both. But I think everybody, it's very stressful for everybody. And so hopefully people are kind of leaning into that and being supportive for their partners at home, for the kids, and recognize that stress exists. You know, I know for myself personally, I participate more on the home front than I ever had before, for better or for worse, you know, so everybody takes on new roles, I think.
I'm sure Judith is happy that you're helping out at home a little more now. So, Dr. Shah, well, how have you negotiated the home work interface or not interface anymore? It's just all happening at the same time at the same place.
I mean, I think one of the biggest advantages to this, and this is like the one upside, is that it's a fortunate side effect. I have never spent so much time with my children before. Like, they're every day of the week in between telehealth visits, I can hang out with them, and they come to me with homework and other types of stuff that I've never been involved in. So there is a definite upside to that time frame right now where there's such limited going in. That's the one upside that I can see from it. And I don't know exactly what will happen when we move past it. I'm in a double physician family, so we sort of flip our time. I go in one day and she goes in the other day, and we alternate when we go in, and the other one takes care of home, because we do have a live-in nanny, because 5 days a week we're working basically, and she's not come to our home for the last 2 months. And we have to reactivate her soon because our practices are starting to get busy again as we start to, you know, ramp up again.
Have you told your nanny that you appreciate her?
Absolutely. This is very, very critical. Their role, I mean, she is so important. She knows it. To make our function, our family function, and to make our work life function. So it's actually become very important. Just one other point I wanted to put out on what Amy had said earlier and about restarting our practices. One of the big concerns about us is resource utilization and PPE. So even though we have such a backlog of cases, to get through them uses a lot of resources, because each one of those cases burns through a piece of PPE per case, per each person that's in the room. And we really can't ramp up again until we know we have PPE to manage a second surge or a third surge. So we actually still are limiting cases with an internal committee that decides which cases go. Amy may be part of it, Tom may be part of it at their hospitals, where you decide, even from the less urgent and more urgent, everyone self-stratifies, and our internal committee decides, okay, this one should go up. As like a Gleason 6 cancer versus a Gleason 8 cancer for prostate or whatever, like which one should go even to be submitted to the hospital.
We won't do a poll on that, but it's a good decision about a 3 versus an 8 or a 9.
Exactly.
Dr. Krambeck, are there issues or concerns you have from going home to the hospital and back? Or what do you do with your clothes? Do you take a shower? Are you worried about bringing something from work home more so than you did in the past?
Yes, I am far more concerned about it now, and I wear a set of clothes into work, then I change into scrubs, then I change back into those clothes, then I change out of those clothes in the garage and take a shower in the garage, and then I go into the house and get dressed. So it's quite an ordeal, I just don't want to bring anything home. And you know, it's kind of amazing. We probably should have been doing this before. In reality, it seems like COVID has cured C. diff and some of the other major issues we had in our hospital. And it's because we're all more aware of cleanliness and sterile technique and limiting transmission.
Yeah. Dr. Chi, what are your thoughts about transitioning from home to work and work to home?
I think Dr. Krambeck's comments are really appropriate. You know, like we have seen such a dip in things like C. diff in the hospital. I mean, it just doesn't exist anymore. So, you know, that level of kind of cleanliness and kind of, you know, washing your hands and not touching your face and all those things, I think it really may change our infectious disease landscape. And, you know, Dr. Shah said there's one good thing about this, you know, spending more time with kids. I've also never showered more in my life, so you know that's the second good thing, I suppose. But you know, it does point out, I think, to us that the problem right now, to me, I think probably the biggest worry is that we just don't understand enough about coronavirus right now to be able to kind of say, okay, well, how far back can you kind of take these safety measures? You know, 4 weeks ago, every newspaper was saying, oh, you got to wipe down your groceries, you got to, you know, make sure you don't bring anything in the house that hasn't been like bleached. And now they're saying, oh, you know, we probably overreacted a little bit. So hopefully over time, a lot of this guidance about what are safe practices to split between your home and your work will kind of come a little more clear. So as we learn more about the infectivity of coronavirus in this particular case.
Yeah. I'm going to go around and sort of ask the three of you sort of a last question for you, and then we can have a summary. Do you think we're going to have a second or subsequent waves of infection coming with large numbers? And if so, how does your institution and how do you prepare for this potential change in the number of cases?
So, am I starting? I missed two.
I was going to ask Dr. Chi since he was still on. I apologize.
Oh, yeah, sorry.
Please start, and then we'll go to Dr. Krambeck, and then we'll go to Dr. Shah in terms of what your thoughts are about the future. Do you think there's going to be a second wave, and how long do you this whole process is going to continue and change our lives?
Yeah, I worry about the second wave, obviously, because we're in California, and every other weekend now is sunny and beautiful, and then you see all this picture of people on the beaches and folks opening up without kind of following careful guidelines and guidance. And I think that the thing that kept California safe, or specifically the Bay Area, the thing that kept the Bay Area very safe was that out the gates with very aggressive sheltering in place and rules about how you should behave outside and social distancing. And it kept our numbers very low relative to others that were heavily hit. And now that we're kind of moving into a phase where folks are loosening that up, I think that if it gets too loose, it'll have the exact opposite effect. And so I'm very worried about people's behavior.
Thank you.
Yeah, I agree 100%. We are anticipating a second wave. That's why we're trying to get through all of our cases now so that we can be ready for that second wave. I think this will go on for years. I think we are forever changed from this virus. And I think until there's a vaccine, we'll be dealing with it until then.
Dr. Shah, are you done with your wave or are you waiting for the next wave?
Our wave is improving, but we're not done yet. We're nowhere close to being done yet, which is what the concern is. And we are anticipating a second surge or a second wave that's going to come through, and possibly a third. Because as we reopen and people start traveling, people from New York who are carriers and people that are from other places will spread it amongst the community again. Because New York has still had bad weather. We actually haven't opened up completely because there's nowhere to go and it's rainy every day and the temperature's cold. We haven't had the fortunate of good weather. So once the weather starts to turn a little bit, I think people are going to be out and about. Right now, it's a ghost town outside in Manhattan. There was like 3 people I saw coming to work as I was walking from the parking lot to our hospital building. But it'll open, and I'm concerned. In our hospital, so our hospital's done separate things in the sense that we have 200 people still on ventilators now. I think there will never be less than 100 ventilators still available. Something of that number, where even when the numbers ramp down, at least for another year, they were going to keep available ventilators in case we need them. The hospital volume will never be as high as it was before as far as surgery, at least for some time, just to allow for a surge. Because we will never be caught off guard, I think, again, if we can prevent it.
Well, I want to just initially just thank everyone giving perspectives from the East Coast, from the Midwest, and from the West Coast. I'm going to let Wei Shu just maybe address some of the questions that we've had from our audience. So we appreciate everyone giving us some of the questions. So Wei Shu, you want to give the first question?
Yeah, sure. Thank you all for the very lively discussion. One of the first questions, I guess, relating to the patient's fear, that's about 1/3 of the poll audience, right? That worry that patients have. What are you doing to address this fear of your patient's fear of coming in? Are you reaching out to the patient? Yeah.
Okay, so I'm going to readdress the question. How are you addressing with patient and family fear about coming to the hospital, Dr. Shah?
It's a true concern. I mean, ours is still overrun by COVID. So we have a fairly high volume. We talk to them beforehand. We try and do everything through telephone visits and telemedicine unless it's an emergency. And we actually have a lot of centers that are like a lot of Columbia has a lot of peripheral sites. We have them get labs and imaging studies peripherally at one of our outpatient sites that has less exposure to the hospital for now, and then do telemedicine visits to go over the results. And anything urgent still comes through, and you try and siphon them off to an area that's less coronavirus. And the numbers are coming down, so it's safer, but it's a major concern still for the New York area.
Dr. Krambeck, what's your perspective?
It was very similar to Dr. Shah. We try to keep them at peripheral sites, keep them away from the main hospital. When they do come into the hospital, we try to send them home the same day. I've done more outpatient PCNL procedures since this started than I ever did in my entire life. They all want to go home immediately afterwards. So we send them home, as long as it's safe.
It's probably safer than we thought.
Yeah.
Yeah.
Just like telemedicine is probably just as good as inpatient visits. Dr. Chi, any other thoughts? And then I'm going to go back to Ms. Tan.
Yeah, I think that you have to be honest with your patients, and I think you have to be aggressive with your messaging, to be honest, and so I think that the patients are concerned, and I think that we're all concerned, the patients are concerned. And I think you have to be honest with yourself too, like right now we know that our test positivity rate for people who are symptomatic at the hospital is like 2 to 3%. And our asymptomatic test positive, as I mentioned before, is like 0.3%. So, honestly, I think it is a safe time for people to come in, and we want to do it now while it is safe before there's another surge later down the line. And so, we're aggressively messaging our patients to let them know, listen, this is a safe time. We think you need to get the care you get so you don't get that septic stone or get that heart attack because you were just waiting on your checkup or things like that. And so it requires, I think, some centralized messaging that's coming from the hospital. We as surgeons have to do outreach as well to our patients because they're going to believe it coming from your mouth a lot more than they're going to believe it coming from a television ad. I think it makes a huge difference.
So is your hospital sending letters out or emails out or text messages to the patients, or are you doing it individually?
Our department sends out, oh, yeah.
After you.
Yeah.
Yeah, absolutely both. Both. I think both makes a big difference, you know, and you see a spectrum across of different hospitals. Some hospitals are actually advertising in the newspaper or on TV, and you know, we've taken a more selective kind of, we're going to message our patients locally through the EMR, through letters and things like that.
Yeah.
That's great.
Dr. Shah, one last issue for Dr. Shah, then we'll go back to Ms. Tan.
Oh, the same question?
Yes.
We're messaging the hospital, everybody. You know, the big concern is that Manhattan hasn't been hit as hard as the boroughs of New York. So you also don't want a hospital labeled as a COVID hospital. Like, this hospital has only COVID. Let's not go there. And patients that are in those communities should know that they should have access to healthcare, because the problem is a lot of people are missing the boat and waiting too long because of their fear of getting coronavirus. And instead they're having heart attacks or septic stones and not presenting until very late in their presentation. And then it's irrecoverable. It's like very difficult. It's an uphill battle, trying to repair the situation that could have been repaired very easily. So there's messaging, definitely. There's a dialogue with your patient that has to occur, and from the hospital system and the government, from New York State government, that you should still go for your emergency care if necessary.
Ms. Tan, do we have another question?
Yeah, actually, right along the lines of what Dr. Shah has just mentioned, I think with this increase in acute cases and sepsis, are there consequences that you're worried about, that you're seeing because of patients' fear and delay of treatment, either from the hospital side or the patient individual side? And what are you doing to address this?
Dr. Shah, very briefly, then we'll go to Dr. Krambeck and Dr. Chi, then we'll go to the next question.
I mean, it sort of was what we were saying, in the sense that we are seeing some delay in care. We have not seen an increased risk of sepsis overall, because I think septic patients still find their way to the hospital. But you know, we don't know what's hit a lot of people. Coronavirus in New York is undercounted because in the past, when somebody passed away in the community, it was not tested whether they had coronavirus or not. Now they're starting to get some numbers on that. So it's more prevalent here than we thought. But it would be interesting to hear what Tom and Amy are doing.
Yeah, Dr. Krambeck?
I think we're seeing far more complex disease right now. So yes, we would stent patients with UTIs and stones. We're not really seeing UTIs and stones. We're seeing florid sepsis and stones. So they're waiting until they're extremely sick to come in. I just had a lady last week who had a solitary kidney and a known stone, and she wouldn't come in for treatment, and she waited till she was anuric to come in. I mean, it's just more advanced disease because people are waiting longer.
Dr. Chi?
Yeah, and I think a first move that we can all be doing is really making sure that we've kept track of the backlog of patients that we had booked before, and then reaching back out to them, making sure that we're checking in with them on a regular basis. And you know, a lot of the patient-facing questions are the important ones, because you know, we have patients who had like I got a patient with a horrible staghorn, was institutionalized, and multiple rounds of sepsis, and they're like, no thanks, no, I don't want to come for surgery. And then I got a patient who's got needs a whole up for like an 80-gram prostate, who just gets up like twice at night. He's like, oh yeah, I'll come in next week. So I think we have to be able to understand how to message to our patients the urgency, so that the folks who really do need to come in, they understand they're not missing that boat.
Yeah. Ms. Tan, maybe one last good question.
Okay, that's tough now.
Yeah.
Well, how about, let's see. How about this testing, right? So I think all of you have mentioned testing in your facilities, and there is this false positive as well as false negative rates. Particularly, I guess, Dr. Shah, you mentioned that you treat all as if they had COVID, but for Dr. Krambeck, perhaps when you mentioned that you do it differently, right? And how do you then address the false negatives that you were not as fully suited during the procedure?
So maybe let me address the question a little differently. Do you trust your tests, number one? And do you trust the tests done at your institution, or do you trust tests at other institutions before they get to your place? Dr. Shah.
Ours is a fairly high accuracy test that we have in our institution from the data that they're giving us. The outside tests are not as accurate as what we have, but there's so many tests out there. And we rely on some of the outside tests when people have been tested within 24 to 48 hours of their surgery. So it's a concern. And the problem is that our prevalence is so high that we actually wear PPE and everything, because there's just a risk of being a false negative.
So the test is, so let me just review. The test at your institution is the same as a test that's from an institution 80 miles away. You look at them as being the same.
No, we don't. We look, because the tests that are outside, I think like the Abbott test and a lot of these other tests have about an 85 to 90% sensitivity. And the test that they supposedly are doing at Columbia is their own test, which has a higher sensitivity. But we don't know. I mean, the data is still out there because once you're false, once you have a negative, you don't actually know when they get positive. Like there's no following these patients. We don't have a tracing system yet in the US.
Yeah, Dr. Krambeck?
So if they're asymptomatic and they're negative, I feel confident in our test. But if they're symptomatic and negative, we still treat them like they have COVID. They have to have their testing done at our institution. Our rapid test is not as sensitive as our standard test. So we really don't use the rapid test for surgical patients.
Dr. Chi?
Well, I think that the important comments that have been made here that people need to carry forward is, one, you have to understand what test you're getting and who is administering it, so that, every place has different tests. There's a ton available, just like Dr. Shah said. So know what you're asking for. So if you're in a position where you're like, I just want to get the surgery on, let's do the rapid test. Understand what that means for you. And also understand what that context is in your infectivity rates, because if you have a high prevalence around you, test accuracy is a lot more important. Whereas if you have a low prevalence, like in San Francisco, because we have a low prevalence, even though our test is only about 85 to 90% accurate for some of the ones we use, if it's negative, it's going to be accurate about 99.7% of the time. So lower prevalence means you can rely on a slightly less accurate test in a way. And so you have to understand those two factors before you decide what you're going to do with your testing strategy. It's really important.
What I'd like to do is sort of summarize this webinar and acknowledge that what our lives were in the past are very different than what they are today and what they'll be in the future. When we all went to medical school, we had expectations of being a physician, being a surgeon, the satisfaction that you have, being able to see patients face to face in the clinic, examining them with your hands rather than seeing them in telemedicine. So when I look at the future is very different. And I'd like to just get closing remarks from each of you in terms of, I'll start with Dr. Shah. How do you perceive your life being different 5 years from now than what it is today and what it was last year?
5 years from now is a fairly big jump. So
okay, let's go. Let me restate it.
I would say I'm hoping.
Let's go to 2 years from now. What do we think that it's going to look like for you 2 years from now in terms of what your practice is, what your aspirations are, and how you deliver care to your patients?
I think we're going to be more effective in a lot of ways, and we're going to be more efficient than we were before, both with surgical care and with our patient visits and things like that. I mean, Tom has brought it up and Amy's brought it up. Our telemedicine, I think, is going to be much more efficient for us for patient visits and push through as far as like seeing and encountering these patients and saving a lot of time. Hopefully we're more productive academically as well. If we're interested in this, you have more time available to do these other types of projects that you may be interested in. So in the academic world, it may allow us to be hopefully to work on projects that we couldn't work on before.
Yeah, Dr. Krambeck?
Well, throughout history, a major world war has always advanced medicine. And I would say this virus has significantly advanced medicine. So we amazingly overnight became adept at virtual medicine. I think the quality and efficiency of care we're going to give will be better too. So I think in some ways the virus has helped us. It's helped us make a leap into reimbursement for quality, being more efficient. I think in 2 years from now, I think 70% of my practice will be virtual, and I'll come in to do procedures and I will work from home more.
And you'll be a better homeschooling teacher at home, huh?
I might have a teacher in my home. I can do it.
Dr. Chi, your closing thoughts?
My hope is that the next phase of what we're going to see is also going to be developing new technologies, and so one, I appreciate Dornier for putting this all together. This is not about the technology, but I do think that as now folks around us start figuring out ways to support healthcare with different technology, I think that's going to be the next phase of kind of transformation for care. What can we do remotely? Like, can you do a fill pull void and not ever have to have the patient come in and using new technology and things like that? And so I'm excited to see kind of that next phase of transformation, I think, for healthcare, and hopefully it'll affect all of us in a positive way.
Well, I just want to thank all the panelists, Dr. Shah from New York City, Dr. Amy Krambeck from Indianapolis, Dr. Chi from San Francisco. I'm going to let Bob Evanson give us his closing remarks, and we really appreciate the support from Dornier.
Great, thank you very much. I appreciate all the panelists being with us today. Dr. Stoller, Dr. Krambeck, Dr. Chi, Dr. Shah, thank you. Very organic and an honest, informative discussion. Very quickly, as our panelists identified, limited PPE has been a real issue. And having full gear of PPE during surgery is obviously being practiced, as Dr. Shah mentioned. I'd like to remind our attendees of the Dornier Million Mask Project and our commitment to the frontline workers and healthcare providers. To date, along with our strategic partners, we've donated over 3.4 million masks. We've recently announced a 1 million mask treatment program where Dornier will be donating N95 masks to patients and to the surgical staff in conjunction with our Dornier Access single-use ureteroscope. And we, quite frankly, challenge all med tech companies to provide N95 masks with their equipment to help protect the healthcare workers and their patients. Thank you, doctors. We appreciate your comments and honest interaction. Please watch for other Dornier webinar series invitations. We thank you for joining, and please be safe.
Thank you.
Thank you very
Thank
much.
you.
Thank you all.
Yeah,
Thank
and
you.
for the audience, please do us a favor and fill up the post-webinar survey that will be coming to you. Thank you very much.
Thank you. Be safe.
Thank you all. Bye.